morning, everyone. My name is Ruth Pecora. I am the Director of Market Development for Medtronic Diabetes in Canada. It is my pleasure to be here today to represent Medtronic on the podium, but I'd like to send a sincere thank you to the CAWC and everyone here for your collaboration in enabling this symposium to take place. I think we're in for a very interesting hour. So just to begin, I'd like to highlight 3 areas of focus that Medtronic does have around healthcare globally. Optimizing cost and efficiency and improving outcomes are certainly key, and that is also with the goal of expanding access for people who currently do not have access to some of the technologies and healthcare that many of us enjoy as a privilege, especially here in Canada. Medtronic has joined forces with Covidien almost 2 years ago, and we have a vast array of areas that cover many spectrums of the chronic disease milieu. But specifically today, we're here to talk about diabetes. So within diabetes, our footprint is definitely expanding in the world of diabetes. That includes glucose control for type 1 and type 2 diabetes, the evaluation of glucose control, bariatric and metabolic surgery, vascular technologies, cardiac, dialysis, and of course, wound care. Diabetes is many things, and I've worked in diabetes for close to 30 years. I come from a clinical background. And one thing that is a constant in diabetes is education. Throughout people's life cycle, their needs change constantly. And everybody in this room, I'm sure, is familiar with seeing evidence of having to adapt every week, year of people's lives as they evolve through the continuum of the disease. Medtronic is very committed to supporting diabetes and education throughout Canada and the globe. Last year, we did full-day programs across Canada to more than 500 healthcare professionals. And this year, we've also started doing that as well, where we're looking at new technologies that actually the pump on the right-hand side was just approved by Health Canada a couple weeks ago. These technologies play a very important role in regulating glucose control, particularly in type 1 diabetes, where people have severe hypoglycemia that can lead to irreversible outcomes, as well as hyperglycemia. The device on the right, the little white shell, is the diagnostic that's basically like a Holter monitor for your blood glucose. You wear it for 6 days continuously, and you get a 6-day continuous tracing of your blood glucose. This type of technology can be very helpful in trying to enable better outcomes of what everybody is here at this conference now today, improving the lives of people living with diabetes and suffering from diabetic foot ulcers, as well as other complications. In these education programs, we do highlight diabetic foot assessment and are starting to gain some ground in getting endocrinologists, internal medicine, diabetes educators oriented to doing this more in a systematic way. It is challenging. Time is difficult. An example of how this technology can also improve glucose control. This technology has the ability to automatically suspend insulin for people who are taking insulin and are dropping down too low in their blood glucose range. When you look across Canada, these are thousands of people on this technology, and the graph at the top represents people who have the automatic insulin suspension feature turned on. So when your blood sugar is dropping, it automatically stops the insulin, which makes sense. If you have type 1 diabetes, you wouldn't want to keep giving the insulin. And the map at the bottom indicates the people who don't have that feature turned on. That is severe hypoglycemia in red, less than 2.8 millimoles. When you look at the number of events that are occurring in Canada, there have been 52,000 full 2-hour suspends where people have not responded to those suspensions of insulin. So it's definitely an advantage for people to keep them safe or safer and improve their quality of life. Prevention is also key. So working with kids and families to preserve wellness is also an important thing that we do. So with countries, Canada, the US, and Sweden, we do a hockey program in Montreal, Niagara Falls, and Milton, where we educate kids and parents through 5-day experiential learning. And even there, we're including a session on skin health, prevention, and care strategies, putting your best foot forward, because we want to keep these kids and families living better longer. It's interesting to see the distribution curve of age of diabetes in Canada, with more than 3 million people living with diabetes. It's important to look at the cohort of people who are aging, and the good news is they are aging. The other news is we need to make sure that the people in the lower end of the age range, that we keep them living better, longer. So with that, it's my pleasure to introduce the symposium and highlight the learning objectives for today. To highlight the importance of prevention and early detection of diabetic foot ulcers in the community, to describe the vascular perspective of the interprofessional team, and to explore the benefits of the tertiary clinic model. So with that, and no further ado, it is my pleasure to introduce the moderator for this morning, Dr. Tej Sahota. Dr. Sahota graduated as a Doctor of Podiatric Medicine from Kent State and his advanced surgical residency from Akron, Ohio. He did 7 years in a Limb Salvage clinic in the United States and has also earned his advanced credentials with the American College of Foot and Ankle Surgeons. Dr. Sahota moved back to Brampton in 2013 with his family and works at the Markham Podiatry Clinic. He is Vice President of the Ontario Podiatric Medical Association and is Senior Faculty of the CAWC. So with that, thank you very much for joining us, Dr. Sahota, and I will pass it to you.
Thank everybody for joining us this morning. It's a great turnout. My role as moderator will be to keep everybody moving. We have a great and diverse panel up here. Each speaker will be speaking to you for about 15 minutes, at which point at the very end we'll have a joint panel discussion and questions from the audience will be taken. I'm also want to urge you throughout the day, if you see anybody from the panel, you can feel free to ask any other further questions. We will all be at the conferences for the day. So without further ado, my first introduction is Petra OConnell. Petra is the Senior Provincial Director for the Diabetes, Obesity and Nutrition at the Alberta Health Services. Since 2012, she's been responsible for developing the clinical and research network for overseeing the design, evaluation, and spread across Alberta. Two initiatives that she's undertaken for the diabetic foot care pathway for use in primary care and for improvement of diabetes management in hospitals. And she's also on the Provincial Steering Committee for the Alberta Health Services. Petra has held senior management positions in strategic and hospital facilities planning, hospital support services, and ambulatory care management. She has degrees in BSc in medical laboratory sciences and a master's in health service administration from the University of Alberta. She's published in the areas of health technology administration, clinical practice guidelines, innovations in healthcare guidelines. Petra OConnell.
Thank you very much, and good morning, everybody. I'm really pleased to share a few moments with you to tell you about our diabetic foot care initiative in Alberta. Just in case any of you recognize this when you came in, this is what I'm going to be talking about for the next little while. So just a few words about who we are. I am with the Diabetes, Obesity and Nutrition Strategic Clinical Network, which was launched in Alberta in the latter half of 2012. And our mandate is to work with patients and healthcare providers across the province to find new ways and strategies on how we can reduce and prevent risks that are associated with diabetes and obesity. And we also want to help people living with these chronic conditions to stay well and healthy throughout their lives. So to that end, the first year and a bit of our existence, we spent a lot of time looking at our diabetes data in Alberta. And we also spoke to many patients with diabetes as well as healthcare providers to find out some of the key gaps in care of our patients. And what we discovered very early on was the increasing trending of lower limb amputations due to diabetes. And as you can see from the graph here, the numbers continue to go up each and every year. We're projecting for 2015-16 that we're probably over the 900 mark. So as you all know, there are many risks associated with lower limb amputations and diabetic foot ulcers. Not only does it increase health risks, but it decreases quality of life and significantly increases costs for both the individual and the health system. But the positive news is that the majority of these can be avoided with early detection and treatment. And so that's what we set out to do. So in looking at the data, we also identified some other important features. We noted that in the case of the prevalence rates of lower limb amputations, there was tremendous geographic variation across the province. In this diagram, the darker the red, the higher the prevalence of amputation rates. And it also corresponded quite closely to the prevalence of poor glycemic control levels, as marked by A1C. Looking a little bit more closely at the A1C data, however, it became quite evident that A1Cs do not actually tell the whole story when it comes to predicting foot problems. We looked at data on all our diabetic foot ulcer patients and also patients who'd had lower limb amputations. And what we found or discovered was that over 1/3 of them had A1C values of less than 7%. So this was a very important message to take back to our primary care teams, that A1C in of itself is not the only marker to be looking at, and therefore we're trying to send the message that you need to do the foot exam on at least an annual basis. Another important piece of evidence that we considered, we did a comprehensive mapping of all our diabetic foot care services across the province in 2014. And again, we surveyed the healthcare providers and patients. And what we discovered was tremendous variation in the types of services and the amounts of services across the province. There were no standard screening or treatment practices as far as diabetic foot ulcers were concerned. And what was very telling was what we heard from patients and primary care providers insofar as they declared that very little attention was paid to foot care in the primary care area. Many patients who'd been diabetics for years and years said, no one has ever asked us to take off our shoes and socks. No one has ever told us to look at asked us to look at our feet. Our tertiary care providers also indicated some frustration in terms of long wait times. Again, there wasn't adequate capacity in the system to discharge patients back into primary care for follow-up and long-term assessment. Again, because the capacity, the knowledge just wasn't there. And then finally, we also heard many comments around frustrations about barriers in relation to therapeutic footwear policies and costs to patients. So in late 2014, early 2015, we engaged a broad community of foot care experts from across the province and across Canada. We also engaged patients and other healthcare providers across our province to develop a diabetic foot care pathway for patients and primary care providers. We were committed to developing the pathway and testing the pathway in several of our geographic communities, evaluating the pathway, and then refining it for future provincial rollout. So this slide basically states the purpose of our pathway, which was to standardize and improve access to diabetes foot screening, early detection, and treatment of foot problems in the community. Here's a sampling of the various tools that we've developed for our healthcare providers and patients. So for our primary care providers, we've developed a risk assessment tool, which is adapted from the 60-second screening tool that I'm sure many of you are familiar with. We also developed a guide to help providers interpret and apply the assessment tool correctly. We developed a triage and referral form to help primary care providers identify when do they refer the patient, for what purpose, and within what time frame. For patients, we also developed tools, educational tools, to help them better understand how to care, to better care for their feet, and also when to seek medical attention. A very important component of our work was to identify high-risk foot teams based in the community. Now, these are not new teams, rather they were pre-existing teams, but based in various settings, including home care and also ambulatory care wound clinics. The composition of these teams, typically they're multidisciplinary, and the teams that we're working right now consist primarily of nurse practitioners, registered nurses, and OTs and physical therapists who all have advanced wound management skills and training. It's very, very important to have these teams based in the community to ensure timely access to the primary care provider who's referring the patients. And the other added feature of our particular program is, unlike before, now these teams will discharge and transition the patients back to the community for long-term follow-up and ongoing assessment. So I mentioned a little bit before that we're testing the tools, and since November, we've enlisted 3 communities across the province with populations anywhere between 25 and 70,000 people. These are quite diverse population areas, and they're based in northern, central, and southern Alberta. We've been collecting a lot of data from each of the demonstration sites on appropriateness of the referrals and the timeliness of referrals. We also interviewed all concerned about their satisfaction with the tools, the processes, and the services of the high-risk foot teams. We're just now looking at our data, and I can tell you our early results are quite favorable. Over 96% of the patients referred are deemed appropriate for referral to the high-risk foot team. And we've also identified that the vast majority of these patients are at moderate risk for development of a foot ulcer. So about 80% have been referred for preventative education and therapeutic footwear where indicated, and about 20% have been referred for actual treatment of an ulcer. So again, that's telling us that the primary care providers are getting more familiar and comfortable with the tools, and they are looking for these patients and referring them sooner. The satisfaction results from both our patients and healthcare providers too were very positive. And what was interesting was our baseline data showed that over 50% of our patients had confirmed they had never received any foot care prior to this program. And moreover, 2/3 of them identified changing their foot care routines as a result of receiving the education through this program. Healthcare providers also expressed great satisfaction with the tools and the processes and their relationships with the high-risk foot teams. One suggestion they made, though, to improve was that they required more standardized training and education on lower leg assessments, vascular care, and to help patients advise them on proper foot care. So in closing, some of the plans that we now are embarking on, we're currently working with 3 larger new communities in Alberta to implement the tools and to identify new high-risk foot teams. Other opportunities that we're exploring, we would like to adapt the tools to use with telehealth in more remote communities. The primary care physicians have asked us to try and embed these tools in their electronic medical records. And we're also working with the government on a new therapeutic footwear policy that would better support prevention of foot ulcers as opposed to the reoccurrence of foot ulcers. So that's what we're hoping to achieve this year. And next year, we're going to be holding 2 foot care symposiums in Edmonton and Calgary. And the hope there is that we can increase the knowledge and the skills on diabetic foot care among our primary care providers further. So in closing, I would like to thank you for your attention, and I would also like to thank the conference organizers and sponsors for this wonderful opportunity. Thank you.
Thank you, Petra. For many reasons, I think Alberta can be a fantastic model for the rest of the country, and you highlighted many of those key points. Next up, we have Dr. Nagpal, who currently works at the Ottawa Hospital serving as Chief of Vascular and Endovascular Surgery. He completed his medical school at Dalhousie University and then worked as an ER physician prior to enrolling as a general surgery program at the University of Ottawa, where he also completed a fellowship in vascular surgery. He's received further training at the endovascular surgery at University of Pittsburgh Medical Center and currently the medical director of the Vascular Diagnostic Center and has been Chief of Vascular and Endovascular Surgery for the past 4 years. His clinical and research interests include optimizing peripheral revascularization and non-invasive testing. He has a strong interest in wound care and currently implementing a multidisciplinary limb salvage clinic at his institution. Dr. Nagpal.
Hello all, thank you for the opportunity to present. Thanks for the organizing committee for asking me to present here today. Limb salvage clinics, and in Canada I don't think this is a frequent occurrence, but in the US where I did some training and certainly and we go to these international conferences, it's a very common practice to have many limb salvage clinics in the community. Is there a timer with the slides? I'll go back to the previous slide. So the major people that we see in limb salvage clinics either have peripheral vascular disease or diabetes, something that we're all, in wound care, that you commonly see. When it comes to peripheral vascular disease, what is the prevalence of peripheral vascular disease and how common is it? And there's multiple studies, but in general, if you take a 40-year-old, there's about a 4% chance that he has peripheral vascular disease. If you take a cohort of 70-year-olds, you're up to almost 30%. And if you take a group between 50 and 69 who've ever smoked or have diabetes, you're up to 30% of the general population has peripheral vascular disease. Now, when we say peripheral vascular disease, there's a broad category. Some people are asymptomatic, they are walking around, have no symptoms at all. Some people are claudicants, and we call that mild or moderate peripheral vascular disease. For limb salvage clinics, we need to concentrate on the severe peripheral vascular disease called critical limb ischemia. Now, critical limb ischemia is defined by having tissue loss, gangrene, which we're all familiar with, and also rest pain. We classify it into critical limb ischemia simply because these folks have a high risk of limb loss, and that's why these limb salvage clinics need to focus on those particular patients. Now, we're all interested in limb salvage, but look at this slide, which I think is fascinating. If you have mild or moderate peripheral vascular disease, something like claudication, your chance of being alive in 5 years is around 80%. But if you have critical limb ischemia or severe peripheral vascular disease, your chance of being alive is only 50% in 5 years, and that's unfortunately an important statistic before us. This is just another reflection of what I just said, and most of us in the room, I think, understand what ankle brachial index is. It's the severity of our peripheral vascular disease. If you have an ankle brachial index of less than 0.4, in other words, have rest pain or tissue loss, the chance of being alive after 10 years is 20%. That just gives you a reflection of how severe the systemic disease is. You're not dying of a leg amputation, you're dying of heart problems, strokes, kidney failure. So it's just a reflection how sick these people are. I'm just going to touch on this slide and the next one. In vascular surgery, we often use the Rutherford classification to decide how severe the peripheral vascular disease is. And they divide it up into minor tissue loss and severe tissue loss, the categories 5 and 6. Now, there's a big push to have a new classification system. And this makes a lot of sense to us, especially in research, because there's tissue loss and there's tissue loss. And this Wi-Fi system tries to categorize it a bit more specifically, because as you know, there are many different ways to heal a wound, and it depends on the type of wound. And the broad categories don't do it justice. So hopefully with this new classification system, we'll be able to define better treatment for specific types of wounds. Well, also, one of the main clients that we see are diabetics. And what are the causes of diabetic ulcers? We all know neuropathy is a major cause. We all know that infection, joint stability are also major issues with diabetic ulcers. Peripheral vascular disease is also a huge issue in these particular patients. Now, what this slide shows is the survival of patients who are diabetics with and without critical limb ischemia or severe peripheral vascular disease. So these unfortunate people with the combo deal of CLI and diabetes, they have statistically different, apologize for the timer here, they have statistically different survival rates. So if you have diabetes plus critical limb ischemia, your survival is much lower. So look at this really scary looking slide. If you have diabetes and critical limb ischemia, this is just 1 year, the chance of you being alive with both limbs is only 50%. 25% have amputations and 25% aren't even alive. So this is a very malignant process. So why focus on diabetes and peripheral vascular disease? I guess half my job is looking after patients with both these particular disease processes. 94% of diabetic foot ulcers have below-knee peripheral vascular disease. Tissue oxygenation, we all know, has the strongest risk factor for diabetic foot ulcers. And we also know that to heal a wound requires a lot more blood than to maintain tissue integrity. So it's important to improve blood flow as much as possible. Also, it's potentially treatable. 60% of major amputations can be prevented by early diagnosis and treatment of the CLI and aggressive treatment of diabetic wounds. So what do we mean by treatment for peripheral vascular disease in diabetes? It's revascularization, whether it's operation or endovascular therapy, which we'll discuss in just a minute. And the main thing we're trying to do is prevent a major amputation. Only 30% of people will get back to independent ambulation after a primary amputation, where 80% of patients will if they have a primary revascularization and getting more blood down into the foot. So the treatment of peripheral vascular disease in broad terms can be divided into surgical treatment and percutaneous treatment. That percutaneous is classified as endovascular therapy. Now, endovascular therapy has just exploded over the past 15 years. We've always had just plain old balloon angioplasty for over 25, 30 years. But over the past 10 years or so, we have bare metal stents, covered stents, arthrectomy devices, which essentially beaver away at plaques. We have laser therapy, drug-eluting balloons. It's just there's something new every year. And it's very difficult to evaluate these treatments, but some of these do catch, and they are improving outcomes for this particular patient population. So look at this slide, which I think is quite interesting. If you look over the early 2000s, the rate of endovascular interventions just exponentially rose near the late 2000s. The number of open operations slowly decreased, and whether this is causal or not, the major amputation rates started to come down as the endovascular treatments started to go up. You can't make a comment on causality, but certainly it's an interesting correlation that we need to keep an eye on if we can reduce major amputations with aggressive revascularization. So what's the best approach? Is it an operation or is it endovascular therapy? Well, endovascular is not for everybody. It's often not as durable. It can actually mess up a future operation for you if you put a stent in the wrong place. Often it needs repeated interventions. It's expensive new technology, which our hospital reminds us of every month. There's really no good long-term data when we compare this to a good old-fashioned open operation. But it's certainly preferable in some situations. If you have a high surgical risk patient, obviously if you can put a needle in the groin and get the job done, it seems like a very attractive option. Older patients, if it's short lesions do better than longer lesions, and I think that kind of makes maybe common sense. If you have just a small ulcer, this might be appropriate because if your balloon only stays open for 6 months, that might be all that you need. Once you get good skin integrity, then you need less oxygen to keep it going. If you have poor vein options is one reason we often do it, because we don't have a good surgical option. But if your patient is young, is a good surgical risk, you have a long, nasty looking blockage, and you have significant foot sepsis or tissue loss, an open operation is often your best option. I'm just going to touch on this. There was one level 1 evidence trial that compared open surgery and endovascular surgery. And in a nutshell, it said if the patient you think is going to live for more than a couple of years, and not all our patients do, if they're going to live for more than a couple of years, surgical therapy likely is the best option. If your patient's likely not going to live more than 2 years, then endovascular therapy is likely best for that patient. Now, this is an international trial which is currently underway, and we're involved in Ottawa. We're just trying to answer that exact question, which is better, open or endovascular therapy for patients with critical limb ischemia. Now, those broad patient demographics are what you're going to see in limb salvage clinics. So if you had a limb salvage clinic, you need rapid access. There's no point if you have a 3-month wait list for someone who's got a gangrenous foot. You need rapid diagnosis, especially when there's vascular problems. You need the ability to have ultrasounds, duplex, angiograms at your fingertips. Again, if you have wet gangrene or significant necrosis, you can't wait months to get these diagnoses organized. You need rapid treatment. You need access to the appropriate people who can get the appropriate resources implemented. And you also need long-term follow-up. It can't be a one and done. You need to collect your data. You've got to be able to compare some of your treatment strategies. Now this was in some 2007 study, some interesting research came out that the implementation of multidisciplinary teams has reduced amputations in various clinics worldwide by 40%. To me, it comes off the tongue easily. That's an amazing statistic. You can simply reduce the amputation rate in communities by 40% by talking to each other and working together. I think that's, like I said, it's easy to say. I'm not sure how it's easy to do, but it's something that we need to work towards. Now, this is also a slide from a 2004 study, which I think is really important. It changed limb salvage clinics and aggressive treatments actually change the type of amputation that we do for patients. Let's say the total number of amputations stay the same, whether you're aggressive or not, but you change below knee amputations and above knee amputations into metatarsals or Symes or Liz Frank type of amputations. You've really helped that patient quite a bit, and I think that can't be underestimated. By reducing the level of amputation is also a big endpoint for limb salvage clinics. Now, there's no one can do the various disciplines by themselves, and I can't stress that enough. I revascularize legs. That's what I do for a living. I can't do what Chris Murphy does. I've tried. I just don't have the knowledge at the time, and like I said, the skill set that she has. I'm not going to look after sugars as well as an endocrinologist. I can't do some partial foot amputations like my orthopedic and podiatry colleagues can. We just have to realize we have our role, but you need a champion. In some of these situations, it has to be a physician champion to push it to the next level. We recently had a conference in Ottawa where we had some international revascularization specialists who run their own limb salvage centers, and we asked them, how can we get ours off the ground, and how do you make yours successful? And you need a champion. You need someone who's actually got to go to these meetings and push it, because it's easy to say no because there's new money involved. So you need someone to keep pushing it forward. So the economics of this are actually quite obvious. Petra had some good slides on that. Limb salvage with vein is 44% cheaper than an above knee or a below knee amputation. It's at least that. These are some American numbers. Limb salvage with prosthetics, 26% cheaper. Primary above knee amputation is 3 times more expensive than limb salvage. We all understand that it's the right thing to do. Apologize, I don't know why it's going like that. Hello? All right, let's go back a couple of slides. Where was I? All right, one more. Let's see if it stays there. No? Okay. Now, in our healthcare environment in Canada, we are not fighting for market share as they do in the States, and it'd be interesting to hear your comments when you worked in the States for many years. I really don't need to be any busier, and in some models that may not be the same. So we're not fighting with the next limb care center across the street where they are maybe in some communities down south. If funding agencies do not see the rationale, it is very difficult to add a service to the hospital within the current fiscal climate. I'll speak specifically for Eastern Ontario. We're broke. It's very difficult to get anything new organized. They're actually cutting for the past 5 years, and I know the next 3-year outlook is not pretty. So getting new funds for new services is a significant challenge. So they're looking to cut costs, and certainly they're not looking to add services. So we went to them, and what are our arguments? Well, the clinical care argument, everyone in this room understands the clinical care arguments, that we can look after, improve limb salvage, the economics of that should be enough to convince most people, but we can also potentially discharge patients sooner if we knew that there was a good wound care follow-up for this patient population. And we can absolutely prevent readmissions. We know that as our wound care time in our clinics get reduced, these patients then present themselves to the emergency department, which taxes the resources there, and then they get admitted, and it just increases costs. But it's in a different silo, and they don't see that, unfortunately. So our other arguments are certainly research. Jesus, what's going on here? All right, research, so it stops, is we need to track outcomes. With the LINS potentially encompassing CCAC in the near future, we'll need to have a liaison between the hospital and community care nurses, and that continuity of care, I think, is a great opportunity to track our outcomes and then go back to the funding agencies and say, look, this is what we did, and this does make sense, help us out here. And I personally do feel that the administrators that I talk to, that they really want to help us, and they do understand the need, but they need the data to back them up to go to the next level and say, we need to get this done. And I see this as a significant teaching opportunity as well, where educational resources that help for courses, we can help physicians, nurses, and students of various disciplines to get to a high level. This initially started off as a project between infectious disease, vascular surgery, and wound care. I apologize for this, I don't know what's going on. We are delighted to have this. We do have orthopedic support, plastics, endocrinology, and local podiatry as well, and all those people having their skill sets are going to be very important with with this project. There appears to be enormous interest from everybody except the financial people. The funding, our institution is unable to support, as I said. We do fortunately have significant industry support. They see the need for this. Obviously, they look at it as a win-win as well for them, but it has to be an unrestricted commitment on a legal side for the hospital, indeed for them as well. And we may be able to get, and I'm hearing indirectly that we may be able to get and have gotten LIN-based funding, which is exciting because that may put our project into the operational phase. And manpower, we've got commitments from orthopedics, plastics, ID, and we're fortunate, very fortunate to have that on our side already. Our limb salvage team, the way I look at it, it has to be, the patient will be assessed by wound care and a vascular surgery rapid assessment team or a form. We'll have standard intake forms with pre-admission vascular assessments with either duplex or CT angiograms, which will help make the assessment very easy for us. But we actually currently have all our skill sets in the same clinic space. If you come to our clinics, you'll walk over to the ID and say, do you mind having a look? And it's that kind of format. It just improves patient care immensely, and we're fortunate to have that. So in conclusion, limb salvage centers are currently rare in Canada. It's great that Alberta is starting this up, but I don't know of any other place in Canada where this is going strong yet. The incidence of PAD and diabetes is expected to rise. In the current fiscal environment, adding services was certainly a challenge. A multidisciplinary approach with early vascular evaluation is mandatory to maximize outcomes. Early adopters must provide data for cost effectiveness. They really want me out of here. To show funding agencies and usefulness of highly specialized teams. Thank you very much.
So one key part that Dr. Nagpal touched on is about limb salvage being financially cheaper, but it's also metabolically cheaper for the patient. And I think that makes a huge difference when deciding which intervention to take. And Dr. Nagpal, to answer your question, unfortunately, the limb salvage clinic and business in the United States is a little too good, and that's probably a problem. Is we're not in competition with each other, and there's a limb salvage clinic in each hospital. In Akron, which is about 3/4 the size of Brampton. If anyone's from Brampton, we have one hospital operating in Brampton right now. In Akron, which is about 200,000 people less, we had 8 hospitals, all of them with a limb salvage clinic. So that tells you how much more of an intervention you can take. My next speaker is going to be Dr. Chris Murphy. Dr. Murphy is a registered nurse with Canadian Nurses Association certification. Her doctoral research investigated the assessment and treatment of lower vascular extremity wounds in the vascular surgery population. Dr. Murphy is an ET nurse at the Ottawa Hospital with specialty in vascular and complex surgical wounds, and has a Master's in Clinical Science and Wound Healing graduate program at the Western University. Dr. Chris Murphy.
Thank you.
And there we go. So I'm going to talk a little bit more about the tertiary clinic. But before I do that, I'd like you to take a minute and think about people who have inspired you to get involved in wound care. Who is it that's influenced you? Why are you here? And we all have different stories. And for me, I think it began with my grandmother, pictured here with my little sister, around 1970 or so. She had gestational diabetes, and years later was insulin dependent, and bumped her toe one day as she was vacuuming because she was a crazy housekeeper. So she went to see her family doctor, and you can probably guess what happened. Why are you in my office with a bruised toe? Why are you cluttering up my waiting room? Don't you know I have patients in my waiting room who have cancer, serious illness? They may die from this. You have a bruised toe. Go home, put a Band-Aid on it. Don't come back. Now, I think we all know now what can happen, and a couple months later, baloney amputation, and we know how that story goes. And now we know, of course, that when you compare diabetic foot ulcer to cancer, in fact, outcomes can be just as dire. And we know where patients end up. So we have become educated since then, and hopefully she wouldn't have that situation now. Fast forward 30 plus years. Now we know things. We come to meetings like this and we learn things about diabetic foot. But the problem's gotten so much worse. Right? We have now what is called the economic tsunami of diabetes. And with this growing prevalence, we have 1 in 4 of patients with diabetes that will get a diabetic foot ulcer, will become patients, people that will become patients. We know that they're at high risk for amputation and hospitalization, and then you start adding peripheral arterial disease to that and things get much, much worse. And that also is not an uncommon problem, as Dr. Nagpal just mentioned. But we also know that a team approach is going to reduce hospitalization and amputation rates. So therefore, the team makes sense. In tertiary care, our clinic, unlike Petra, who is focused on prevention and early intervention, is focused on the advanced diabetic foot syndrome. Patients with multiple comorbidities, falling apart, big wounds, and often arterial disease, because we tend to look in a vascular area. And they require, as Dr. Nagel said, rapid access to specialty care. And so it's great when you can walk across the hall and grab an infectious disease person, a vascular surgeon, plastic surgeon, orthopedic surgeon, and so on. But also in a tertiary clinic, we can offer rapid access to things like debridement, skin grafts, antibiotic adjustments at the same visit. And in doing so, we can put together a whole plan and help the home care nurses see that patient through to success. Because often the home care nurse is a different nurse every time, and a knee-jerk reaction by the home care nurse, who maybe hasn't seen the patient before and they're not doing photography or anything like that, they're just going to order more and more supplies, and you end up with a stockpile of stuff that's never used. So you need a bigger plan. And of course, a tertiary care model is a perfect environment to have development of database, research, and education. So how do you engage a team? When you're starting out, where do you begin? Maybe it's intimidating to talk to people that you normally don't talk to. Maybe they're not interested in wound care. You can start by approaching people that are really keen on wound care, like the people in this room. Or you can start by approaching people that have to do a lot of wound care, just because we know that they're seeing more and more wounds, so they may have an interest. Some people may be married to their old practices. They want to do that saline course 4 times a day because it's cheaper, and that's it and that's all. So you pick your battles and you talk about rationale and you come to consensus and you get buy-in over time. You don't try and throw the book of best practice guidelines at people and get them to uptake in a minute. You get buy-in, you start the academic conversation, and you figure out where people are coming from and you hear them. You can offer education opportunities which don't have to be formal education. You can educate people during a clinic visit, other clinicians during a clinic visit. You can educate people by the way you document. I choose this treatment because I want to address this issue and I want this result. Document that way. People read your documentation over and over again and they start to uptake the information. When you get people together, new ideas pop out and you get improved care. And as Dr. Nagel was saying, if you have that seamless team without walls into the community, then you're really golden because you're going to get seamless care. Because our patients do go from inpatient to clinic to outpatient to back to inpatient to clinic, and so if you can have a big plan, then they're likely to stay home. Of course, we need to recognize that the patient is the center of that team. And we now know that patients you need to realize that patients, of course, know how they feel, and if you can engage that patient in wanting to better their own health, then you're going to get better results. And you can use techniques within your culture, like motivational interviewing, where patients set goals for themselves and timelines and are held accountable by their own means to get better results. Finding a space is often the most difficult thing. Real estate is often the most difficult thing when you're setting up a team like this and you want it to be centralized. But don't let that stop you. When we started with our clinic, I was in this one little room in an old, century-old building with little narrow hallways, and I'd have to go along the hallway and up a ramp to see Dr. Nagel and the other vascular surgeons, or if I wanted infectious diseases, I'd have to go downstairs a floor. But still we managed to communicate and we built our team. So don't let real estate stop you. Now, as he mentioned, we have this beautiful 4-bay area for wound care that is directly across the hall, literally 5 steps from the vascular surgeons and 20 steps to the plastic surgery team, who have this lovely little couple of operating rooms so they can do minor procedures such as skin grafts on the spot, same visit. When the granulation tissue is ready, send the person down the hall, get the graft now. Don't wait 3 weeks until it's dried up later before you can get an appointment, etc. And this open environment for our wound clinic actually works pretty well because patients end up with peer support as well, and they all say that's a great benefit. But the key benefit, of course, is going to be rapid access to surgical care. Used to be that our plastic surgeons weren't terribly keen on putting skin grafts on people who had ischemia, vascular patients, and then on a load-bearing surface on the foot, because they said, oh, you need something durable there, it needs to heal on its own. But when you're in the same environment, you can start having these conversations over and over again and say, well, yes, but it's going to take 2 or 3 months to heal that wound. And in that time, they may have a limb-threatening infection. And if we close it now, maybe they won't. And so they started doing more skin grafts on these wounds. And guess what? They heal. And guess what? They're durable. So we're starting to see that more and more. Antimicrobial management is key. Our infectious diseases team are right there, and they'll come down pretty much to any appointment that they need to. Especially with ischemia, with arterial disease, we are at high risk for infection. We're actually very interested in that area of research now that there's biofilm and there's antibiotic stewardship and so on. We're very interested in wound hygiene and cleaning up fluids and what that all means. This is an area of research for our team, and as mentioned, we recently completed a randomized control trial on ultrasound debridement. So future needs, what do we all need? We need a database. We're starting a database in our clinic, but we need our database to match the outcomes that other people are measuring so that we can compare notes and see who's doing well and copy what works and discard what doesn't work. We need to make the financial case with that database. We need widespread education. The clinicians that aren't in this room, the family doctors that aren't in this room that are providing that first-line care, and the emergency room physicians and so on, we need to get our message out there. And also the consumers of care, so the patients and their families, so that maybe they can, from the beginning, try and avoid this trajectory. Work similar to Petra's. We'd love to have that model in our region. We need to bring the academic conversations that we're having in conference to our everyday environment and put ourselves out there and do that and improve things. And we need a funding model. Of course we need Canada-wide, we need to not be piecing things together. We all know this is going to be cheaper to actually give effective care at the end of the day. So our challenge? Diabetic foot ulcer care is complex, but it's inconsistently provided across the way. There are still amputations that may be avoidable, and that's a shame. But we have this opportunity now to transform the care for diabetic foot ulcer, for the patient and for the system. But we're still in a situation where we don't have total contact casting for everybody available. We don't have uploading footwear available for everybody. Like these really basic things that can help us out a lot. They're not expensive. Hopefully the next generation will know a time when care is coordinated better. So a happy ending, I'm just going to tell you that it is worth it. This is a patient that we followed a little time ago, and she came in with a critically ischemic limb. She had wounds down to her bone. You can see malleable wounds down to the bone. She also had a plantar wound on her first metatarsal head. And the A word had been mentioned, but she came in to see our team, and the vascular surgeon that saw her said, no, we're gonna have a go at this. Gave her a bypass, infectious diseases, meticulous wound care, hyperbaric, all that kind of package, and she managed to heal in 11 months. And she came in that day, and you'll notice maybe that she's sporting a rather large diamond ring on her wedding finger. It was their 60th anniversary, and she said, oh, thank you to your team, because without this, I wouldn't have been here today. It was so worth it. And what I'm telling you is it is worth it. Build your team. And if you need information or inspiration, then you're at the right conference. Thank you.
Wonderful, thank you. One of the take-home messages from this panel, you've probably heard the word over and over, is multidisciplinary team effort. Dr. Nagpal talked about having champions that will advocate for this, and I hope that when we leave here, 500 or 600 attendees that we have all go back to their communities and become champions for a multidisciplinary approach to limb salvage. It takes a Petra, it takes a Dr. Murphy, it takes a Dr. Nagpal, it takes a myself, and it takes a whole lot of you. But together, we can make a difference in Ontario, and at the very least, try to catch up to Alberta. We don't like to be behind Alberta in anything, right? So, I have a few questions that I'm going to initiate for the panel, but I would like to invite any questions from the audience. There are microphones situated on either side, so if you can line up. My first question for Petra, you had mentioned the larger cities, and I saw some of the towns there. I'm from Edmonton, so I'm familiar with some of that area. Is there a mechanism in place for the smaller communities, the communities that are up north, to initiate a call to one of the larger centers that you have throughout your centers, or are they isolated from the larger limb salvage clinics?
Is this on?
Yep.
Oh, yes, it is. So right now, in terms of the limb salvage clinics, most of that has to occur between the larger centers, so Edmonton and North, which is why we're trying to reduce some of the pressures through this preventative action. And you'll note that one of our demonstration sites is actually based up in the Slave Lake area.
Sure. So I think that's going to be one of the challenges for us is as we start initiating these limb salvage clinics, we'll get funding for Toronto and Ottawa and Hamilton, but what do we do about Sudbury and Timmins and Thunder Bay and throughout the provinces? In British Columbia, we can get something for Vancouver, and what happens to Kamloops or Kelowna? So that's going to be one of the models that we're going to have to examine about how we initiate calls from the smaller communities to use the resources in the larger communities. Dr. Nagpal, just a real quick question. You mentioned ABI. In the diabetic patient with calcific stenosis, have you found any use for transcutaneous oxygen measurements or TCOM values? Is that something that you partake in your practice?
We do have a TCOM machine that we initially used for assessment for possible hyperbaric therapy. But instead of TCOM for diabetics, we have toe brachial indexes, and we have a lab, which very high functioning lab, and they know right away just to go straight to a PVR on the toe to give you an assessment. Where, as you correctly pointed out, that toe brachial index does not work on patients with calcified vessels, and diabetics fall into that category, renal failure, and sometimes just older patients have calcified vessels, so we use toe brachial index.
Okay. Dr. Murphy, in your tertiary care clinic, once the patient has been established, talk about the role a nutritionist can play in participating in the care for me, if you can, please.
So the nutritionist does play a critical role. We need to have them eating well. Obviously, if they don't have the building blocks for tissue repair, then they're not going to move forward and heal. Typically, they're examined when they're inpatients as far as access to the dietitian. And at that point, blood work will look at how they're eating, their A1C, and all of those kinds of things. In the outpatient clinic, we don't yet have a dietitian direct, but we have sent people out to community care associated dietitians when they're struggling.
Fantastic. Thank you. So we have questions from the audience. If you can kindly introduce yourself and then ask your questions of the panel.
Bonjour, my name is Jeanette Laberge. I work out of Eagle Lake First Nation. As you're aware that our First Nation people have critical diabetic foot ulcers with multiple comorbidities. How can we refer them to Ottawa to have appropriate treatment? I work out of Northwestern Ontario. I have a client that goes to Thunder Bay for wound management and then goes to Winnipeg for vascular surgery. And they seem to be butting heads. So it's really encouraging that there is a team that works well together, and how can we get them to you so we can salvage their limbs. Thank you.
It's probably easier to solve the Middle East crisis than that. It is a very big issue in Ontario. In fact, I'm on a committee to look at vascular care throughout Ontario, and northwestern Ontario is very difficult. Even though you're part of our province, the expedited healthcare either goes to the U.S. sometimes, or it actually goes to Winnipeg. Thunder Bay did have a vascular surgeon, which I think just moved out to Edmonton. Thanks, Petra. But at the end of the day, Limb salvage does mean assessment, and it's fine to be assessed, but you need treatment, rapid treatment as well. And that's why sometimes having a limb salvage clinic in smaller communities is good for the assessment part, but then you need access. If you're asking how we can get them down to Ottawa, we do see a fair amount of patients from Northern Ontario, and that have to come from a procedural infrastructure process. We're happy to see these patients. We actually do see a fair amount, but if there's a way that we can help get these folks down to us, I'd be happy to facilitate that. I know Thunder Bay has a direct connection with the Toronto Vascular Division. That may be the access point, but I certainly know that they go to Winnipeg because that's the closest major Canadian center.
All right, go ahead.
Linda. My name is Linda. I'm from Nova Scotia, and I am a foot care nurse, and I've been doing foot care for 15 years. The great advantage that I have is that I get to see my clients every 6 to 8 weeks, and that's something that I try to teach, especially people that are coming into the pharmacy where I work with other diabetic problems. I try to convince them that if they're able to come and see me every 6 to 8 weeks, at least someone is looking at that foot. And I think this is where it starts, is with the foot care nurses. So I think it's important to include us as part of that team before it even gets to that other stage.
I encourage anybody in the audience to seek out Tom. He wrote a great paper on a call to action, and I thought it was really well done. I'd like to, on behalf of Medtronic and the CAWC, thank everybody for attending, thank our panel, they were excellent. And we're going to be around for the duration of the conference, so if you do have an opportunity, please pull us aside and ask any questions that you may have, and we'd love to speak one-on-one and talk about individual communities. And again, thank you, and we're sorry for running a little bit over time here. Thank you so much for your contribution.